We're going to go over a little bit of the epidemiology, the pathophysiology, treatment, some of the controversies in management, and then the prognosis of people that do suffer crush injuries. And this is kind of an example of obviously a disaster that would lead to significant injuries. And this comes from a picture of an earthquake in Turkey in 1999. Certainly pray that we never have to be involved in anything like that. I can't imagine taking care of injuries. But we're going to talk a little bit about some of the definitions of crush injury and crush syndrome. And from a recent consensus meeting, I found this kind of interesting. It's really profound. A crush injury is a direct injury resulting from crush. Seems pretty self-evident there. But crush syndrome, though, is the systemic manifestations of muscle cell damage resulting from pressure or crushing. And that was from a consensus meeting. Other definitions that I think I like better is crush syndrome is a clinical condition caused by compression of muscle with subsequent rhabdomyolysis, which is the breakdown of muscle cells, rhabdomyolysis, which can cause then complications of electrolyte disturbances, fluid sequestration, and myoglobinuria. And we'll be talking about myoglobin. Myoglobin is a protein that's in muscle that gets released with cell destruction and creates a lot of the problems. Another definition would be it's a form of traumatic rhabdomyolysis that occurs after prolonged continuous pressure and is characterized by systemic involvement. So crush syndrome includes a localized crush injury along with systemic manifestations of muscle cell damage such as shock, rhabdomyolysis, and renal failure. Some of the history behind crush syndrome goes all the way back to the Bible and the book of Numbers. Scholars think that the descriptions of death from illnesses that involved muscle pain and weakness was probably actually some sort of a rhabdomyolysis syndrome. Dr. Larrey, Napoleon's surgeon, also described limb gangrene in people with carbon monoxide. But really the first description of crush syndrome in the English language was written in 1941 by Dr. Bywater, who described development of dark urine, renal failure, and shock, and ultimately death in patients who sustained crush injuries during World War II bombings. And he later, as we'll talk about in just a bit, did some further studies, autopsy studies, to identify myoglobin and myoglobinuria as the cause of renal failure that he witnessed. Now, some of the causes of crush syndrome, again, and crush injury, really, that leads to crush syndrome. One, it's an immobility against a firm surface for greater than 1 hour. Drug or alcohol intoxication as people fall down. We do see this. I've seen several of these type of patients. They fall, they're incoherent, they'll lay for several hours. Carbon monoxide poisoning, and again, with unable to move. Cerebrovascular accidents where people fall, can't move. Head trauma with coma. Certainly the elderly with hip fractures. Something we have to deal with in surgery is the improper positioning of surgical patients, the same with ICU. You have to keep changing the patient's position. Because again, lying against, although a firm surface for 1 hour, and obviously our ICU beds are soft, but still patients have to be moved or they can develop pressure sores. Assaults with beatings where people can't move. And that's something we don't see too much of anymore is the mass trousers. I haven't seen a mass trouser, but the mass trousers, when they're insufflated, have to be taken down occasionally because of the potential for developing a crush syndrome. And in the United States, actually alcohol intoxication associated with prolonged muscle compression is the most common cause of traumatic rhabdomyolysis. Other causes of mass casualties with crush syndrome includes building collapses by earthquakes, landslides, bombings, construction accidents, heavy snow on roof, and then minor trench collapses. These are some of the earthquakes over the last 40 years that were significant. Some of the pictures we have are from these accidents. Certainly with unfortunately, going across the world, the terrorist bombings that are occurring and the destruction of buildings and collapse. Now, in these MASH casualty events, these are rough estimates from the literature, but basically 10 to 60% of survivors extricated from collapsed buildings, or 10 to 60% of people will survive in these injuries or these disasters. Up to half, though, may develop renal failure, and at least half of the people that develop renal failure will require dialysis. Typically, again, reviewing the literature in these mass disaster events, about 20% of injured are hospitalized, and anywhere from 5 to 20% of those have crush injuries, with up to 1% eventually needing dialysis. Again, in Central America, underdeveloped places, incidence of crush syndrome is much less, where residences are just single story. Obviously, with most natural disasters and building collapse, a lot of the victims won't make it out of the building to a medical facility. And the causes of immediate death are these: severe head injury, traumatic asphyxia, and then intrathoracic and intra-abdominal injuries. However, causes of early death, and these would be people that get out of the rubble, and these are examples of what we're going to talk about as far as crush syndrome, is hyperkalemia, hypovolemia, and causes of a later death includes renal failure, coagulopathy, hemorrhage, and sepsis. So apart from direct trauma that kills people, crush syndrome is the most common cause of death in earthquake victims, and the most common cause of death in these victims includes hypovolemia, hyperkalemia, and circulatory failure. Now, some of the pathophysiology of crush syndrome. It's interesting. Usually the problem to the tissue is not necessarily or just usually directly related to tissue ischemia. But the most prominent type of body muscle is skeletal muscle. The skeletal muscle cell membrane, also known as the sarcolemma, is a key factor in ensuring normal cell function and monitoring normal cell structure. The cell membrane contains pumps that move potassium and calcium into the cells and sodium to the outside. However, with mechanical stress, you get damage to the sarcolemma membrane, resulting in disruption of this membrane. You get sodium and calcium that instead of being flushed out of the cell are now able to move into the cell or stay in the cell. You get fluid that moves into the cell, and this redistribution of fluid leads to third spacing and cell swelling and shock. So again, you get the result of the cellular swelling, you get increased intracellular calcium, you get disruption of the cellular functions and respiration, you get the decreased ATP production, and subsequent muscle cell death. And part of this process, and we'll be talking about compartment syndrome, is why muscles swell, because the cells themselves are swelling that can lead to the compartment syndrome. Now, some of the systemic sequelae of the crush injury and then the crush syndrome, with the result of death of muscle cells and leak of intracellular metabolites into the systemic circulation. You get the release of these superoxide anions. You get these free radicals. They cause further membrane injury. Excess intracellular calcium leads to persistent muscle contraction, depletion of cellular energy, and cell death. Calcium also triggers several molecular cascades, including the production of free oxygen radicals. These free radicals activate neutrophils, releasing proteases and more oxygen radicals, creating this cascade of events that cause myocyte destruction. As a muscle cell dies, these toxic chemicals get released. They build up in the cell. However, blood vessels, also have to be mindful, are crushed. And so blood can't necessarily move into and out of the into the area. But then when you get rid of the force that's creating the injury, that's when you get these reperfusion injuries and when you really see the problems develop. So once the crushing force is removed from the body, blood is suddenly able to circulate to and from the muscle, and this causes this reperfusion syndrome. Toxins produced during myocyte necrosis are suddenly able to circulate to the kidneys and rest of the body. Fluids diffuse rapidly into the muscle cells, as I was saying, which causes this massive fluid shift and third spacing. You also then get the release of potassium into the circulation, which we'll talk about, that can cause cardiac arrest. In fact, 20% of earthquake deaths occur right after extrication. So prevention of this phenomena by aggressive fluid resuscitation prior to extrication is important in the management of crush syndrome, as we will be discussing shortly. So metabolic derangements from crush syndrome include hypovolemia with fluid sequestration in the damaged muscle. Plus, people are also going to be bleeding usually from other lacerations and things with these injuries, all this leading to hypovolemia and shock. You get hyperkalemia, you get hypocalcemia due to the calcium moving into the muscle cell. Then you get hyperphosphatemia. And then the metabolic acidosis, which is real important when we talk about the myoglobinemia and myoglobinuria that occurs. And again, all this representing shock. And basically right here, this is the shock or the crush syndrome. Now, skeletal muscle, as I mentioned, contains high concentration of myoglobin, which is an O2 binding protein. It's what allows our muscles to get oxygen, or helps with getting oxygen during the times of exertion. Myoglobin itself is nephrotoxic, and it can cause acute tubular necrosis in the kidneys. Additionally, myoglobin reacts with proteins in renal tubules to form casts, which subsequently obstruct the renal tubules. Both free radical formation and cast formation are enhanced in an acidic hypovolemic environment, which is present in the crush syndrome. Hypovolemia and obstruction of renal tubules leads to vasoconstriction, which again worsens renal ischemia. Now, normally, a release of myoglobin into our tissue is not necessarily detrimental because it's soluble in blood in the presence of a normal pH. However, as mentioned in the shock syndrome, in the process, then our urine becomes acidic, and that's when the myoglobin can be very toxic. Bywaters, again, the gentleman I mentioned earlier that was the first in the English language to describe the crush syndrome, he further did some post-mortem studies on the people who died, and in his microscopic examination of the kidneys, he discovered debris and casts of a brownish pigment that he later identified as myoglobin. Basically, bywater studies showed that acid urine is required for the myoglobin to cause renal injury. So at a pH of less than 5.6, myoglobin dissociates into its two components, globin, which we believe is non-toxic, and then the ferrihemate, which is the true toxic component. Now there are, just to mention a few other clinical syndromes where we can see crush syndrome that have nothing to do with crush injury per se. We see a similar situation in tumor lysis syndrome with people that have a high tumor burden, and sometimes chemotherapy and or radiation treatments will do their job, but also the killing of the tumor cells releases chemicals that are similar to crush syndrome. See it occasionally with heat stroke. We'll see it with exertional rhabdomyolysis. Marathon runners release a lot of myoglobin into their urine during marathons. And then also with high voltage electrical injuries, we have to be mindful of a crush syndrome type of process ongoing. Now, as far as the clinical features or in the diagnosis of crush syndrome, they're not necessarily real helpful sometimes, as they may be highly variable and non-specific. Some patients will have little or no signs of any external injury. In the Haiti earthquake in 2010, which our own Dr. Sheehan had gone over to help in the aftermath, investigators basically found the most common clinical signs in patients with crush syndrome were rather kind of generalized processes: abdominal pain, generalized weakness, and muscular pain that was sometimes independent of the crushed area. Again, discolored urine, pink, red, or brown, can be an early sign of rhabdomyolysis. And then later signs include malaise, fever, tachycardia, nausea, and vomiting. Now, patients will also often have some evidence of extremity trauma, such as skin injury, erythema, ecchymoses, abrasion, or swelling. And again, somewhat vague, but these are things to be attuned to in a crush injury type process. The actual extremities may actually not be very painful, actually be more numb. And it's kind of interesting that actually direct arterial injury in crush injuries is kind of rare. So pulses may actually be palpable in spite of significant crush injury to a limb. However, as mentioned, patients may have little or no signs of external injury initially. In fact, the majority of people with crush syndrome don't necessarily have serious skeletal injuries. They can, but the majority don't. However, as time progresses, the compartment syndrome can occur, and this is where we'll see severe pain in the limb, weakness in the limb. People begin to have paresthesias. Pallor, the extremity will look white, and there can be loss of pulses. And these all may be indicative of the compartment syndrome. In the Kobe earthquake in Japan, investigators analyzed predictors for the development of crush syndrome in victims, and basically these were the three things that they found. That basically patients that had a tachycardia or a heart rate of over 120, there's more than a 3-hour delay in getting them out of the rubble. And if they had abnormal urine color, these were the most predictive signs that the patient was going to develop the crush syndrome or was developing the crush syndrome. Another important lab abnormality is the creatine kinase, or also known as CPK. That's kind of in my era, that's what we called it, was creatine phosphokinase. Now it's just called creatine kinase. But it's an enzyme that's found in skeletal muscle. It is the most sensitive marker for rhabdomyolysis. It's the most sensitive predictor for development of renal failure, and mainly because it's slow to degrade. It's more reliable than myoglobin in predicting severity of muscle injury. And basically, CKs or CPKs that are greater than 75,000, that person is probably going to develop renal failure. So it is an important lab value that we'll mention a little bit later when we're following people with crush syndromes that should be monitored. So as far as the diagnostic testing in patients with crush injury, EKGs should be done as early as possible, and it might help us look for signs of hyperkalemia. And this is why in the field, even while the patient may still not be extricated yet, doing EKG monitoring, if at all possible, should be performed. Handheld fingerstick blood analyzers for people in the field should be used to identify hyperkalemia early. And then this routine blood work, once we get to the hospital, just typical things that we're going to order in most trauma people, but they're certainly important for crush injuries. And then radiographs as appropriate. And basically all of these results will indicate blood loss and need for transfusion, certainly pick up electrolyte abnormalities, will pick up kidney function, and hopefully give us the extent of muscle damage that may be ongoing, certainly with the CPK and the myoglobin checks. Now, the cornerstone of management for crush syndrome and injuries is basically fluid resuscitation. Massive fluid resuscitation is usually required for most patients and should actually be started, if possible, extrication. All the studies have basically shown this, and that's why the field workers are so important, that with the patient still being under the rubble, if you can get an IV going, it's very important. The preference is normal saline versus Ringer's lactated, because Ringer's has some potassium in it. And again, one of the problems with crush syndrome, as we've talked about, is hyperkalemia. And Ringer's may actually worsen the hyperkalemia. Again, it's shown that if it's started early, it may prevent fluids, may prevent the development of renal failure. And as mentioned, retrospective studies have shown that there's a great improvement in renal failure rates where the earlier fluid is started versus later. It's interesting, the rates that these people require are quite high. Most young adults may require up to 1 to 1.5 liters per hour. I mean, that's 1,000 to 1,500 cc's an hour. I mean, that's a lot. When you think about our maintenance IV, we run on people is 125. With kids, it's 20 cc's per kilogram and about 10 cc's per kilogram per hour for the elderly. But still, 10 cc's per kilogram in the average, quote, average 70 kilogram man, that's still 700 cc's an hour. I mean, that's a lot of fluid. Obviously, Foley catheters need to be placed to monitor urine output. And some references want to give enough fluid replacement that you'll get 150 to 200 cc's out per hour. The recommended daily fluid administration is somewhat controversial, but sometimes up to 20 liters of fluid maybe need to be given in a 24-hour period, with most studies indicating that at least 6 liters of fluid probably given in the first several hours. In crush victims, as we've kind of alluded to, the serum potassium level should be obtained as soon as possible. In the field, iStat devices are available to the first responders to measure potassium levels. And as mentioned, portable EKG devices can be done and may give some indirect evidence of hyperkalemia. So hyperkalemia in the crush syndrome can occur very quickly after extrication. It can be quickly fatal. As remember, I mentioned in one of the earlier slides, one of the early deaths was hyperkalemia. Hyperkalemia may occur long before manifestations of renal failure develop. Sometimes they occur without signs of the compartment syndrome, and as mentioned, they may require pre-hospital treatment. So victims can develop hyperkalemia very quickly after extrication, and cardiac arrest can occur in the field. So early responders should be prepared to treat hyperkalemia with these things here: insulin and dextrose, beta agonists, and sodium bicarb. So once an IV is going, sodium bicarb usually should be administered in 50 to 100 milliequivalents. The aerosolized albuterol is a beta agonist that can be given. The thing about calcium, and this is one of the controversies, calcium gluconate in a hospital setting in a non-crush syndrome is one of the treatments for hyperkalemia. But in the crush syndrome, it's somewhat controversial because, as noted, although hypocalcemia is common in crush injuries due to the sequestration of calcium in muscles, however, it can be liberated, as mentioned with the reperfusion syndrome, from the muscle during resuscitation. And so people may be prone to actually hypercalcemia, and then giving calcium to treat hyperkalemia may be dangerous. So as a rule, it's not really recommended to give calcium to treat hyperkalemia because of the potential for hypercalcemia, but certainly if someone in the hospital setting is manifesting symptoms of hypocalcemia, they may need calcium, but it's not recommended for the initial treatment. Now, alkalinization of urine is recommended after extrication to prevent the development of renal failure. As I mentioned in the shock syndrome, our acid is going to be our urine is going to be acidic, and that's what leads to the destruction of the myoglobin, which injures the kidney. So alkaluria increases the solubility of myoglobin in urine and prevents the precipitation and trapping within the kidney of the myoglobin. Additionally, alkalization may prevent metabolic acidosis and hyperkalemia. So the goal is to obtain alkaline urine, and that means a pH of greater than 6.5. And you may need up to 300 milliequivalents of bicarbonate even in a 24-hour period for treatment. Now, forced diuresis can be achieved also with Lasix or with mannitol, but furosemide or Lasix is not recommended because it actually has a tendency to acidify urine. And so although there's no definite proof that mannitol prevents crush syndrome, it has been recommended by the Renal Task Force in crush syndrome. Mannitol may help eliminate myoglobin from the kidney and thus prevent renal failure. It may be useful to initiate diuresis in a patient who has adequate normal saline on board but whose urine output is still less than 2 cc's per kilogram per hour. Other advantages of mannitol in the crush syndrome, as mentioned, it may help eliminate myoglobin from the kidney and thus prevent renal failure. It may be useful to initiate diuresis in a patient who has adequate normal saline. It also may scavenge free radicals in muscle, thus limiting necrosis. It has a positive effect on the heart, but most important, it may help to decompress compartment syndrome by mobilizing fluid from the damaged muscle cell and thereby preventing fasciotomy, which we'll talk about here in just a second. This is the mannitol dosage. Mannitol should be given actually as a test dose first, and then repeated doses only if there is a positive response and urine output remains adequate. Giving 0.25 grams per kilogram IV over 10 to 30 minutes is how it should be instituted. And we should see a diuresis effect in about 15 to 20 minutes. The maximum dose should be about 2 grams per kilogram per day or 200 grams per day. There is contraindications to using mannitol, and basically the one is established anuric renal failure, meaning someone's producing no urine. And although it's somewhat confusing, as mannitol, although it's a diuretic, it also does promote intravascular volume expansion. It can cause severe congestive heart failure. Now, compartment syndrome. Normal muscle compartment pressures are less than 15 milligrams of mercury. Pressures greater than 30 milligrams of mercury produce muscle ischemia, so fasciotomy is indicated if pressure is persistently above this. Irreversible muscle damage occurs after about 6 hours of pressures over 30, and nerve damage may occur after 4 hours of ischemia. Now, patients with a higher diastolic pressure can tolerate higher tissue pressures without ischemia, so fasciotomy is recommended when compartment pressure approaches 20 milligrams less than the diastolic pressure. However, if patients are hypotensive, they can have significant ischemia at lower compartment pressures. So when should fasciotomy be done after a crush injury? Fasciotomy is a mainstay in the treatment of compartment syndrome when compartment pressures rise above 30 milligrams, as I mentioned. Until the 1980s, fasciotomies were pretty much routinely performed on crush victims with compartment syndrome, often without any confirmation of compartment pressures. However, there is recent conflicting data on the efficacy of fasciotomies in compartment syndrome, and practices are changing. In most reports of mass casualties from earthquakes, most of the fasciotomies are done more than 12 hours after the time of trauma. And reviews of these cases have shown higher infection rates with increased mortality, amputations, and poor long-term function. Israelis have, with their bombings and the crush syndromes that they're seeing, they basically had better results when not performing delayed fasciotomies. So fasciotomy would be indicated if the victim can be extricated and receive definitive medical care within 6 hours of injury, but not later. If initial compartment pressures are normal and delayed compartment syndrome develops, then fasciotomy may be needed. But the trend right now is to try to get away from fasciotomies if at all possible. But again, close monitoring of the compartments with the needle and the pressures. Now, other treatments for crush injury, obviously oxygen supplementation. This kind of goes without saying. Most trauma patients, period, are going to be getting oxygen, but it may help with ischemic muscle. Obviously, people are going to be in severe pain. You must also, can't forget, we have to address the tetanus status of the patient. And again, as mentioned, Lasix should not be given for diuresis as it tends to make acid urine. Now, some of the field rescue considerations for people with crush syndrome. A lot of times in these buildings that crush, there's a lot of dust. I still have the images in my mind of the 911 and the collapse of the World Trade Centers. Remember when they came down and all the people running and all the dust that was present. So face masks to protect from dust inhalation needs to be available for the first responders. Obviously, if the buildings are unstable, they have to be stabilized before medical treatment can be given. And again, starting IV normal saline as soon as possible is just extremely important. And obviously ventilation, it's hard to imagine these scenarios where these buildings collapse, but you can have gas leaks, you can have all kinds of generators that are trying to apply generator, and it's creating this the carbon monoxide. So people have to be, as soon as they can be extricated, removed to areas where there's good ventilation. Now, monitoring the crush syndrome patient, you have to do urine outputs, and urine pH is hourly. It's recommended that serial electrolytes be done about every 6 hours. CPK, BUN, creatinine about every 8 to 12 hours. Obviously, ABGs if the patient stays acidotic or is on the ventilator. Patients may need central lines for all the IVs and potentially could need Swan-Ganz placed if the patient has cardiac or pulmonary disease. And it's recommended that compartment pressures be performed about every 4 hours. Other injuries that we see in crush syndrome patients, there is a high incidence of associated injuries. I did mention that extremity fractures occur, but they're not real common, but certainly lacerations are common. With crush injuries to the trunk, you can have abdominal wall compression injuries, and they're muscle injuries. You can have traumatic asphyxia, as mentioned, if chest is compressed. Mentioned that dust inhalation is common when concrete buildings collapse. Fires are common in earthquakes, so people may have burn injuries, smoke inhalation, the carbon monoxide. And then people, obviously, depending on their time of exposure, maybe hypothermia or maybe hyperthermic. All leading to, again, difficulty in taking care of these rather complex patients. Now, the mortality related to crush syndrome in earthquakes, most on-scene deaths, as mentioned, are due to direct head or trunk trauma. Of those extricated, mortality reports vary from 0 to up to 60%. But mortality, we do know, does increase with age greater than 50, meaning people have more chronic illnesses. And obviously, people that are healthy, a crush syndrome is hard enough to survive, let alone if you've got other illnesses. We know the duration of entrapment as a part in the mortality, with almost no survivors after 5 days. This is a picture of the Nimitz Freeway back in 1989. I believe this was a as I recall, a triple-decker interstate, and it just completely collapsed. And there was about 42 deaths, which to me is pretty remarkable that it was that low. Just a little word about amputations. Basically, amputations of an extremity should not be performed solely to prevent crush syndrome, because it's been shown that this actually causes higher mortality rates. In the earthquake in Turkey, there was a 30.5% mortality with amputations and a 12.5% mortality without amputations. There are two circumstances, however, where amputation may need to be done. Number one is to free the patient from the disaster site, which I can't hardly imagine doing that. But if it's going to keep the patient alive, it may need to be done. And then an unsalvageable limb or life-threatening sepsis originating from infection in that limb is another reason for amputation. Infection in crush syndrome, the most common sites are wounds and lungs. The organisms with the wounds are typically what we're going to see with any type of wound. It's going to be staph and strep. In the lungs, it tends to be Pseudomonas. Risk factors for developing infection, including duration, time under the rubble. Actually, renal impairment, most of these people are going to have, and then as mentioned, fasciotomies have increased risk of infections. It's recommended that antibiotics not be given just empirically, but unless wounds appear infected or surgical procedures are planned. But if antibiotics are used, then Ancef for gram-positive and Cipro for gram-negative. And it should be mindful that these may need to be renally dosed because these people tend to have some renal impairment. The prognosis, the major risk factors for renal failure: if 2 or more limbs are crushed, there's increased risk of renal failure. As mentioned, insufficient early IV fluids can lead to renal insufficiency, and delayed presentation to the hospital. Children seem to be a little lesser risk for need for dialysis. We're not sure why. 50% or more may have severe long-term limb disability if fasciotomy is done. And patients often need some long-term physical therapy and may need counseling due to their traumatic event. Some disaster planning aspects related to crush syndrome. There's always a need in mass casualties in these situations to have access to an increased number of hemodialysis machines. And there actually is a renal disaster relief task force that was developed by the International Society of Nephrology that's been organized to bring multiple machines to a particular disaster region if needed. Pre-hospital personnel need to be supplied with extra face masks and respirators. And again, pre-hospital personnel need to have access to large amounts of IV fluids and amps of bicarb. So in summary, crush syndrome is a systemic response to local muscle damage characterized by rhabdomyolysis, acute renal failure, hypotension, hyperkalemia, and metabolic acidosis, and hypocalcemia. Carefully assess patients with drug overdose or alcohol intoxication for crush syndrome, and that is something we see here. We seem to see it more in the winter too, so we have the element of hypothermia. Patients should be administered fluids during extrication to prevent renal failure. The patient should be accessed quickly for hyperkalemia and associated injuries. Urine alkalization and forced diuresis with mannitol should be considered to prevent myoglobin precipitation in the renal tubules. And then creatine kinase, or CPK, is the most sensitive test for detecting and predicting risk of renal failure. And if extrication is greater than 6 hours after injury, it's recommended not to perform a fasciotomy for compartment syndrome. And obviously, careful monitoring after admission to the hospital. And this guy was in the wrong place, wrong time. So, any questions? Thank you.